All right, we are live. So, hi everyone. We will wait for about 15 people to join today's very personal stream for me, and I believe it's going to be a very interesting one. So, if you're tuning in already, please get your friends, your family to join this stream. I believe that it will be very beneficial for them. It's going to be an exciting stream, and we would like you to share this if you think it will benefit someone. So give this stream a like, a love before we officially begin. And like I said, today is going to be a personal one because of my guest and also the topic and what I've been through. So once we've gotten 15 people, I'll officially begin. We just need a few more. It looks like the numbers are jumping up. I see more and more people joining the stream. Today wow, I guess a lot of you are joining the stream. Now we have 31 people on the stream. So I'm going to begin. Hi, everyone. Welcome to Talking Live with Macy. Thank you for spending your Sunday here with us. And more importantly, as the COVID-19 cases are rising, we hope that you are practicing the SOPs, staying home if you don't need to go out, and staying safe. Today's topic is a very personal one for me because of what I've been through. For those of you who don't know, I'm a colorectal cancer survivor. And today's topic is on preparations, post-surgery recovery on gastrointestinal surgery, and also gastrointestinal health. For those of you who don't know what gastrointestinal surgeries cover, it covers everything from the esophagus, the stomach, the small intestines, the large intestines, rectum, liver, gallbladder, and the pancreas. It covers a huge area, basically from here all the way to the rectum. And when I talk about colorectal cancer, because I'm a colorectal cancer survivor, colon resection surgery is also a part of gastrointestinal surgery. And colorectal cancer is the second most common cancer here in Malaysia. So we need to take note of that and also be aware of our gastrointestinal health. Hi, everyone. For those of you who've just joined the stream, please continue sharing this, staying with us, because we also have a health screening package worth 600 ringgit to be given out to 2 lucky winners from Prince Court Medical Center. Stay with us till the end and I'll announce how to win it. Thank you so much, Prince Court Medical Center, for sponsoring those 2 health screening packages worth 600 ringgit. And during the time when I had colorectal cancer, I had a very good surgeon. He's here with me today. He's the special guest. And he's also currently my consulting doctor. I go to see him for my yearly checks, my colonoscopy. And because of him, I'm very, very grateful that he helped me, advise me during the point when I was having colon cancer, and he also helped me reverse my colon resection, so I don't have to wear a colostomy bag anymore. That was a nightmare for me. So thank you so much, Datuk Yunus. He is none other than Datuk Dr.Yunus Gul. He is a consultant general and colorectal surgeon, and he also specializes in minimally invasive surgeries and also gastrointestinal surgeries. So he has vast experience in the field, and it's time for you to ask as many questions as you want because he is here today. It's very hard to get his time. So start asking your questions. I'll pick them up towards the end. And once again, I'll announce how to win those health screening packages from Prince Court Medical Center at the end of the stream. Thank you so much, Prince Court Medical Center, for bringing Datuk Dr. Yunus on stream today. And thank you so much, Dato, for joining the stream. I know you are a very busy person.
Thank you, Maisie, and wishing you and all your fans a very good afternoon.
Hi. So I will quickly jump into the questions because I think a lot of people will have questions for you. So I'm going to start asking the questions. All right? Thanks. Once again, Datuk. So my first question for you is, as you have vast experience and knowledge in the field of surgery, could you share with us what made you specialize in the gastrointestinal area?
Maisie, you gave quite a nice introduction about the gastrointestinal tract early on, about the different components of the gut and the different organs involved. And it's that variation and the complex interactions that you have between the different components of the gastrointestinal system that made me interested in pursuing a career in gastrointestinal surgery. I mean, the length of the gut, for example, from the mouth all the way to the anal canal, ranges anything from about 25 to 30 feet. You can see how long that is. So it's a long way from one end to the other, and interposed with that, all the different organs that is involved with the gut to make sure that the gut functions in a normal manner and in a healthy state as well. So when I was in med school, the initial kind of learning of physiology, anatomy, the gut was an interesting component of that education. And when I did my internship, I found that patients who were undergoing surgery, we were able to cure them at a faster rate, and seeing them recover from their ailments, especially in patients who had cancer, was very satisfying. And what had another major impact on me is the explosion in the interest in laparoscopic or minimally invasive surgery, because it was during my early training years that laparoscopic surgery, especially in Ireland, which is one of the focus points of the development of many different laparoscopic gastrointestinal surgery, started in the UK and Ireland, apart from the US and other parts of Europe. So being in the focal point and being working in a teaching hospital, which also had research facilities, had a major impact on me deciding to pursue a career in gastrointestinal surgery.
Well, I'm glad you did. You're very skillful, Dato. So my next question would be, my symptoms for colorectal cancer were basically frequent diarrhea, which led my dad to basically force me to go to see a gastroenterologist because he thought I had H. pylori. But what are the other common symptoms you have encountered here in Malaysia for colorectal cancer specifically?
Yeah, I think one of the things you have to do, Maisie, is thank your dad for forcing you to see a doctor, a specialist, because age-wise, I think it's extremely important to remember that in the day that we live nowadays, ailments can hit you at any age. And I think what we tend to forget is that when you're young, you tend to think that you are immortal and you may not suffer from any serious conditions or disorders, or you may also recover from serious conditions very quickly. Nowadays, even a simple gastroenteritis, so-called simple, can become very complicated. Yeah. So your father did the right thing in forcing you and pushing you to see a specialist. So when you mentioned about the component of diarrhea that you had, is one of the gastrointestinal symptoms that's associated with the development or the presence of colorectal cancer. So we call that an alteration in the bowel habit. So as individuals, we normally have a pattern of our bowel opening. I mean, some individuals open their bowels once a day, some twice a day, some do it alternate days, some do it either 2 or 3 days, right? So if that is the norm for you, and suddenly you find a change that may persist for more than 2 weeks, then the alarm bells should start ringing that there is something wrong and there's something not quite right. And I think that is the time whereby you need to pursue and see either your general practitioner or a specialist. Now, the other symptoms that are associated with colorectal cancer is rectal bleeding. Now, as we know, rectal bleeding is common. I think in our lifetime, at least 1 in 10 of us will suffer or will have symptoms of rectal bleeding. And the majority of the times, is due to a simple condition related to either hemorrhoids or piles, or it may also be related to what we call an anal fissure, which is a tear that you get in the anal lining, which can be painful, apart from associated with rectal bleeding. So now, if rectal bleeding persists and is associated with other symptoms, such as the passage of mucus, that becomes a worrying symptom. The other symptom that you may have is what we call, in a medical terminology, we call it tenesmus. And what it actually means is the sense of incomplete evacuation of your bowels or your stools. So even though you've gone to the toilet, you've evacuated your bowels, you still have a sensation that there's something there. Now, this is associated in patients who have rectal cancers, not for colon cancers, rectal cancers. So we've talked about alteration in our bowel habits, rectal bleeding, passage of mucus, a sense of incomplete bowel evacuation. Some patients, what happens is that they have anemia, which is a drop in your hemoglobin levels, and you may feel weak or tired. So what can happen is that you may have dizzy spells, or let's say when you're walking, or even if you're, let's say, involved in sporting activities, when you try and run, you get breathless and you feel tired very quickly. These are the kind of patients who may not see the blood in their stools, but they may be bleeding very slowly, and it's something that can happen over a period of a few months due to a tumor lying in the colon. And most of these tumors tend to be on the right side because they've got about 5 to 6 feet length of the colon to travel through before the blood becomes apparent. But most of the time the blood is digested, so it doesn't become apparent to the individual or to the patient. So if you do your routine blood tests and you find that your hemoglobin levels are low, then that should also trigger some alarm bells to ring as part and parcel of symptoms associated with colorectal cancer. More rarely is the presence of a so-called lump or a mass that you can feel in your abdomen. That's more towards the latter stages of patients who have bowel tumors. So these are some of the common symptoms that are associated with colorectal cancer, basically.
Okay, thanks, Datuk. Would you say that all of the symptoms you mentioned, are they towards the later stages, or it can be at early stages as well?
Now, I give you a good example for early stages. Some patients are fortunate in the terms of, let's say, rectal bleeding. Now, there are some patients, this are more so in the older age group. And I'm talking about older age group, I'm talking about patients who are also 50 years and above. Let's say if they have a cardiac history and they go for intervention for their heart, and the doctors put them on aspirin or antiplatelet therapy, that makes your blood thin and you tend to bleed easier. So in this kind of patients, if they have a tumor present, they can also bleed in an early stage. So in these patients, rectal bleeding could be an early manifestation of a tumor present. So if these patients take the liberty of having this checked out, they're fortunate enough to have their tumors detected at an early stage.
I see. Okay, thanks, Datuk. So besides myself, have you met other young colorectal cancer patients? If yes, is it increasing over the past few years?
Maybe fortunately, we don't see that many patients in their 20s. I mean, the ones in their 20s, usually there is a genetic predisposition in these patients associated with familial adenomatosis polyposis coli, the FAP syndrome. The so-called sporadic cancers are more common, and they are the ones that we need to be aware of, because the genetic ones, you will have a family history, and let's say the parents or the siblings would already be on the radar, and So they will be followed up more rigorously or carefully by the specialists or doctors concerned. What is of more concern or worrisome is the so-called sporadic cancers, because they are the ones that can be missed if you develop it at an early age. And what we are seeing nowadays is that there is an approximate 2% yearly rise in the incidence of colorectal cancer in younger patients. When I say younger patients, I'm talking about those that are below 40 years of age, yeah? So 20 to 40 years of age. In Malaysia, I would put the figures to be well below 10% at the moment. But in the Western countries, we are seeing a 2% yearly rise in the increasing incidence of colorectal cancer. We're seeing a slight reduction in the incidence in older individuals, older patients, but we're seeing a rise in younger patients. So, I mean, your next question is probably related to why are we seeing this? And I think we have seen the development of diseases in this part of the world that mirrors or reflects what has happened in the Western world. So, I mean, if we were to take, or if we were to add one and one together, you can see that this is a price we pay for development. And as we achieve a developed world nation status, I think we've also inherited the common problems that they face in the Western world, which includes the diseases there, cancer being one of the top and foremost issue that we need to tackle. So we are talking about the prevalence of obesity, sedentary lifestyle, and other environmental factors which are related to toxins. So I think these are very important factors that we need to look at. Another important factor that is common missed out and not talked about is the bacteria in our gut, actually, Maisie, which may in certain individuals have a protective effect. So the so-called microbiome in our gut could play a very important role in the development of cancers, including colorectal cancer. I think a very good example of this, Maisie, is the issue of what you mentioned early on about Helicobacter pylori. Your dad was concerned about it because not only does that make you more prone towards developing peptic ulcer disease or gastric issues, but it's also associated with an increased rate of developing gastric cancers. So very similarly, we have not identified a specific bacteria or microbiome that's associated with the development of colorectal cancer, but many researchers are actually looking for a link, if it does exist, between the presence of such alteration in our gut that could lead to the increasing incidence of the development of colorectal cancer, especially in younger patients, because that could change everything. What is worrying, Maisie, is the survival pattern that we see in younger patients is much worse than older individuals. Yeah? So the tumor tends to be more aggressive in younger individuals, and you have a higher rate of mortality. Maybe one of the factors is what I mentioned early on. I mean, maybe they tend to present at a later stage because remember what I mentioned early on, when you're young, you don't think that, you don't think that you may have cancer. And so you may present at a later stage. And a very good example of this, which was highlighted by the media recently, was the star of Black Panther.
Yeah.
Chadwick Boseman. That was a good example. So
Datuk, you would say that mine was a sporadic cancer because I had no family history of colorectal cancer, right?
Very likely, Maisie, absolutely. Because if you were to look at your family history, I mean, you were the only one who developed rectal cancer. Yeah. And in fact, it's interesting also, Maisie, because we are seeing in younger patients, the so-called age group below 40 in the Western world, for example, most of the tumors tend to be so-called distally or distal cancers, meaning that they tend to lie in the rectal region. So, which is something that you had as well.
Yeah. Okay. So my next question is, there's various schools of thoughts, but would you recommend surgery prior to chemotherapy or chemotherapy then surgery for colorectal cancer patients?
It's a little bit more complicated to answer this question,
In
maybe,
layman
because
terms?
I tell you what, I mean, if I have a patient sitting in front of me with colon cancer, now we need to divide colorectal cancer into colon cancer and rectal cancer, right? And there's a reason for it. The rectum, as you know, lies in a very confined space in the pelvis, and its relationship with the organs in the pelvis. Say, for example, in the males, you have the prostate gland and you have got the bladder, but you've also got the bony pelvis at the back to be content with. Yeah. In females, we have the gynecological organs, got the vagina, the uterus, the cervix, the bladder, and once again, everything sits in a very confined space. So when the tumor grows, there's a greater tendency for the tumor to spread and invade the surrounding organs much easier in the pelvis because of the close relationship of the rectum with the surrounding organs. Yeah? In comparison to the colon. And for colonic tumors, if you have a patient that presents to us, the gold standard is surgery. Wherever possible, we perform surgery first. This may change in patients who present with metastatic disease or patients who have spread, let's say, for example, to the liver. And now, if the tumor is not bleeding, if the tumor is not obstructed, if the patient were to see an oncologist, because we prefer to deal with patients in a multidisciplinary manner, whereby we get an oncologist involved as well when there is metastatic disease. If the oncologist were to recommend that the patient receives chemotherapy first to help downstage the tumor and to treat the liver component, for example, and if the patient has not got any obstructive symptoms or signs on the investigation that we perform, or the patient is not bleeding, then the patient can go for their chemotherapy first to downstage the disease and then have surgery later. The reason why I'm saying that is because if you were to have surgery first, and let's say if you were to develop a complication from surgery, and let's say if you were to have delayed healing or recovery from surgery, that may delay future treatment with chemotherapy, for example. That's the only reason.
Okay.
So for colon cancers, that holds very true. So wherever possible, surgery first. Yeah.
Okay.
Now for rectal tumors, a little bit different because of what I mentioned early on. Patients with rectal tumors, it depends on the stage of the tumor. So for early tumors that has not spread beyond the walls of the rectum, you can consider performing surgery for these patients first.
Okay.
And then you send the specimen to the lab. Now, if it's shown that the tumor has not spread to the lymph nodes or the glands, you can then keep the patients under surveillance. If the patients have got involvement of the lymph nodes, then the patients will need chemotherapy. The difference in management of patients with rectal cancers are those who have tumors that have spread beyond the walls, and especially so in low rectal cancers or mid-rectal cancers, maybe, because when you want to resect the rectum for every patient possible, you will want to join the bowel back together.
Yes.
This becomes challenging in patients who have rectal cancers because if the patients have got tumors that are very low, you may not be able to join the bowel back safely because you may not have enough sphincter function for the patients to be continent after surgery, or you may even leave tumor cells or tumor tissues behind. if you were to perform surgery first. So for this group of patients, it's been shown that they will benefit from having chemoradiation prior to surgery. So what the chemoradiation does is that it shrinks the tumor, makes it smaller, and in some patients, the tumor may even completely disappear. You will find that in some cases, we investigate the patient by doing MRI scans, by doing endoscopy, taking biopsies. We find that there's no more tumor present there. It may still come back, but the fact that it's disappeared gives us a chance for us to resect the tumor and to join the bowel back together. So that is the advantage. So that is the differences that we face in patients who have colon and rectal cancers. But what's very important, Maisie, is that the multidisciplinary approach that should be present between the surgeons, the oncologists, and the gastroenterologists.
Thanks, Datuk. To those of you who have your questions, I will pick them up in just a short while. I have about 2 or 3 more questions, and then Datuk Yunus will get to all of your questions, all right? So my next question is, how would you determine whether a patient should do laparoscopy or open surgery?
Maybe I think in this day and age, as we have advanced, I'm more biased towards laparoscopic surgery, Maisie, because of multiple reasons. It's not only from a cosmetic point of view. Of course, for single females, it makes a huge difference in doing laparoscopic surgery, and it's been shown right from the beginning when we started off doing laparoscopic cholecystectomies, and then for appendectomies, and then for cancers of the gut, that the recovery is much quicker in patients who undergo laparoscopic surgery. So we're not only, you look at the scars, and if you look at the wound healing, what you see externally also reflects of what goes on inside or underneath your abdomen in terms of the healing that's going on inside your gastrointestinal structures. From a cancer point of view, in terms, if you compare open versus laparoscopic surgery, if you look at the recurrence rates and survival, it's almost similar. Yeah, but from a recovery point of view, it's always quicker with laparoscopic surgery. And the other important issue that I see is that patients who have open surgery sometimes have got very long scars. And what can happen is that either months or years later, they can develop this so-called complication called adhesions. Adhesions means that the bowel sticks to one another. And it may also stick to the wound that you have. So the longer the wound, the more likely that you have bowel loops that are sticking to the abdominal wall. It may kink and cause an obstruction or blockage. And this patients may present back to you as an emergency with bowel obstruction or blockage. So laparoscopic surgery has been shown very clearly to reduce or negate that effect. And similarly, if you've got very long wounds, let's say wounds that get infected, you will have the risk of developing a hernia through that wound of yours. And once again, this is reduced with laparoscopic surgery. So even from a long-term point of view, we see less complications with laparoscopic surgery. So first and foremost, if possible, laparoscopic surgery.
Yes, I agree. It helped me with my wound healing.
Perfect.
Less keloids. So, Datuk, what are the common surgeries that you usually conduct with patients at Prince Court? Could be.
As a surgeon who specializes in gastrointestinal surgery, it's divided between emergency work and elective surgery. For emergencies, for example, patients who come in with appendicitis, which sometimes can be very simple. And by the way, removing your appendix can be the easiest operation, and it can also be the most difficult operation. So a lot of people think appendicitis is something very simple. Not necessarily. My advice, or one take-home message that I'd like to give to everyone, is that if you have symptoms of abdominal pain that persist for more than 12 hours, do see your general practitioner or a specialist, because early treatment means early recovery and less complications. We see many patients coming in with perforated appendixes who think that they have food poisoning or misdiagnosed as patients with so-called, the Malay terminology of angin or wind or gastric-related symptoms, because patients who present with appendicitis very commonly present with upper abdominal pain initially, and it's only at a later stage, 12 to 24 hours later, that the pain then migrates to the lower abdomen on the right-hand side. So that's an important thing, appendicitis, just in terms of acute appendicitis. So apart from that, patients may present with abscesses in the anorectal region, so-called perianal or ischiorectal abscesses. Patients coming in with hemorrhoids-associated complications such as bleeding or swelling due to thrombosis or blood clots developing within the piles. And thankfully, we don't see that many patients coming in with perforated guts nowadays because of the effective treatment that we have with medications. And most patients now have early access to their general practitioner and specialists, so usually they are managed or treated quite rapidly. From elective surgery point of view, the colon and rectal cancer surgery, then hernia surgery, patients who have groin hernias, incisional hernias, patients who have hiatus hernias, and these are the common surgeries that I do perform at Prince Court Medical Center.
I see. Thanks, Dato. And my last question for you before we take everyone's questions would be, when should a person start screening, such as colonoscopy or endoscopy? The common age is above the age of 50. Am I correct? Or would you advise younger?
I think you are absolutely right in using that age point of 50 years to begin or start screening, and that's something that's adopted even in Western countries. There has, however, been a recent shift, even though not very strong recommendations, but we're beginning to see a shift in terms of advising patients to have their colonoscopy a little bit earlier. 45 years of age is something that would be recommended, Maisie, because remember what I mentioned about patients developing cancers at an earlier age, now at a younger age. And I think even the American Cancer Society has begun to advise the population to have colorectal cancer screening at an earlier age. So 45 is a better age to start. And also, Maisie, for those who have got a family history, you need to start a little bit earlier than 45.
Okay. Thank you so much, Dato. I believe those are my questions. I think there are many questions, so I'm going to take it from the first few questions. So to those of you who are tuning into this stream, I will announce how to win the 600 ringgit vouchers from Prince Court Medical Center in just a bit, but we will now pick up questions from all of you first. So the first question is, Danny asks, how would you define diarrhea? Is it serious or normal? And, is it watery or solid? How long will the diarrhea last? 6 months? Blood in stool is not visible to the eye. So how can we know that there is blood in the stool? Actually, that's true because I had blood in my stool, but I couldn't see it.
See, the frequency of bowel motions, remember what I said earlier, Maisie, is that what is your normal pattern? See, unless you have changed your dietary pattern, have you gone on a diet? Have you added a supplement? So you need to look at those factors as well. Now, one of the things that we commonly face nowadays is that many individuals eat food from outside, basically, because of the lifestyle that we lead, and this leads to a greater incidence of patients developing food poisoning. Now, most patients who develop food poisoning or gastroenteritis is usually something that's self-limiting, that may last for a few hours, or sometimes it may last for a day or two. And sometimes it can be very serious and severe and lead to toxic or septic complications, right? So the complications related to infective diarrhea is usually short, self-limiting, but some of them need treatment in a hospital setting. So anything that goes on, as I said, for 2 weeks or more is worrying, Maisie, because in a patient who has or who is recovering from gastroenteritis, sometimes the bowel habits may not return to normal until about 2 weeks later, because some of these patients are treated with antibiotics or the bacteria in the gut changes. So that may in itself lead to a change in your bowel habits as well. So it takes time for adaptation to take place and for your normal bowel function to return. But if this goes on for more than 2 weeks, certainly I would call that worrying. Now, apart from the frequency of bowel motions as well, I mean, you want to see whether the stools are watery, because the definition of diarrhea is actually more to do with frequency than anything else. And most of the time, the stools are loose. Now, seeing blood, as you mentioned, can be difficult because it depends on if there's a tumor present, where the tumor is. Is it lying in the rectum, or is it lying further up or more proximally in the colon? For a lesion that lies in the rectum, you'll be able to easily see blood. But for something more proximally, it's going to be more difficult.
Okay.
So I said persistent diarrhea or change is a worrying symptom and would mean that it's necessary for that individual to seek medical attention.
Okay, noted. I hope that answered your question, Danny. And Santan asked whether a person should be concerned of piles. And does colonoscopy or endoscopy screening, is it effective to detect cancer? Or should they do further tests?
Another good question, Maisie, because I think it's a good idea never to take anything for granted. If you have one episode of rectal bleeding, or 2 episodes, let's say, over a period of a few weeks, you may safely say that that's related to hemorrhoids. But if you have persistent rectal bleeding over a period of a few weeks, or maybe even a few months, I would treat that a little bit more seriously. I normally tell my patients that I said 99% of the times you are right in saying that it's due to hemorrhoids, but it's that 1% chance that you may miss the presence of something more serious, such as the presence of rectal cancer. So, I mean, it's always a good idea to get it checked out and not take things for granted, because what some of us do is that we go to a local pharmacist, friendly pharmacist, who may prescribe you over-the-counter medications such as suppositories or other pills called Teflon, which has got anti-inflammatory effects. And sometimes the symptoms may get better, but that does not mean that you do not have something more serious, because what if you have the coexistence of both hemorrhoids and a rectal tumor there? So even though your symptoms may get better over a period of a few weeks, that does not mean that you do not have something more sinister. So, as I said, persistent symptoms that goes on for a specific period of time, do get it checked out and don't take things for granted that it is hemorrhoids. Maybe you were mentioning early on about younger patients having rectal cancer, and one patient comes to my mind when I was working in KL Hospital. 21 years old patient who had been treated for hemorrhoids for 1 year by his local doctor, and had an advanced rectal cancer when he came to see us in our clinic, and that had invaded the surrounding structures. So 21 years of age, advanced rectal cancer after 1 year of treatment. After 1 year, yes, after 1 year of treatment, 1 year treatment for hemorrhoids. Just shows you, you can never take things for granted. So it's always a good idea to get it checked out.
So Santan also asks whether colorectal cancer is associated with diet.
Certainly, yes. Remember what I said early on about us having a westernized diet. Now we're talking about refined foods. Very few of us nowadays have got the time to prepare our own lunches or dinners, even breakfast. Most individuals leave home so quickly nowadays to beat the traffic that they don't even have time to make their own breakfast. I cannot emphasize more, Maisie, about the importance of home cooking. We're talking about fresh food, fruits, vegetables, whole grains. If you were to look at if you were to do a search on individuals who live longest in different parts of the world, let's say even if we don't want to live to 90, 100 anyway. I mean, it's the quality of life that's important at the end of the day. But just from a comparison point of view, yeah, I mean, those people who live to 90, 100s, the cities that they live in, I give you a few examples. Okinawa in Japan, there's a town in Costa Rica, Nicoya, Alcaria in Greece, yeah, and Sardinia in Italy. If you were to look at the diet of the population there, it's mainly quite rich in whole grains. You're talking about the Mediterranean type diet for the Italians and for the Greeks, for example. And that shows you, I think it's a very good example of why those people live longer. So a lot of it has got to do with our diet. I normally tell my patients, yeah, your food is your medicine and your food is your poison. I think if you live by that, you can't go wrong.
True.
So try and reduce your consumption of outside fast food, refined foods, and go more for whole grains and freshly prepared foods. Yeah, salads. Yeah, you're talking about your antioxidants. Yeah, so think about that, and pulses.
Thanks, Datuk. Okay, Audrey asks, I'll just generate, a few of them ask, how can one prevent colon or rectal cancer? I think that's a very subjective question, right?
Well, I mean, coming back to what we mentioned earlier on, avoid a sedentary lifestyle, be active, be physically active, get yourself involved in sports and exercises. You are what you eat at the end of the day. And remember, if there is a so-called proven theory of the gut microbiome, your diet plays a very important role. So you're never too late in starting. Please do remember that. So the best time to start is now. A change in lifestyle. Avoid the sedentary lifestyle. Avoid putting on too much weight. Obesity is certainly a factor associated with the development of tumors. And unfortunately, Malaysia is one of the chief culprits in having a very high obesity rate in Asia. So that is something that we need to tackle badly.
True. Thanks, Datuk. Thanks, Audrey. I hope that answered your question. She also asked whether if a person does not have symptoms, should they do an annual checkup or something?
Depends on the age, Maisie. I mean, once again, from a pre-employment point of view, you'll find that there are quite a number of the employers who will send their employees for health screening. And we also have so many labs available now who do provide packages from a health screening point of view. Just a word of warning is that sometimes you get a very comprehensive list of tests that are being done, which includes tumor markers and whatnot. Now, it does not mean that you have normal tumor markers, that you do not have a potential or possible cancer present. Yeah, do remember that. So it doesn't mean that if you were to do a comprehensive blood test and all your tumor markers came back negative, it means that you're free of cancer. You still may have an early cancer, or you may have a type of cancer that does not produce certain tumor markers that may be present. So from a symptoms point of view, it's very important. Anything that's different to what you're experiencing, do get it checked out. Don't just rely on your blood tests, even though it's a good thing to do, but don't just rely on that.
Okay. Irene asks, can hemorrhoids bleeding be a symptom of early rectal cancer if a colonoscopy done is already cleared?
Rectal bleeding, if it has been evaluated by a specialist. Now, the evaluation usually requires an examining finger, because if you were to do a colonoscopy without examining the lower part, you may miss a very low tumor. So it's very important for the specialist concerned to examine the lower area as well, especially the anal canal and the lower rectum. And if a colonoscopy has been done, it's very unlikely that there is or you do have presence of rectal cancer. If you do not or you have not had a colonoscopy present, then you should have one to ensure that you do not have the presence of a possible tumor. Once again, depends on the length of symptoms that you've had and the age group as well.
Okay. And Stacy asks that you mentioned people with family history of colorectal cancer should do colonoscopy slightly earlier. So can you define what it means by slightly earlier? For example, she had stage 3 colon cancer at 25. So how old should, for example, her children be screened in the future?
If she had stage 3 colon cancer at the age of 25, one of the most important questions we want to find out is that, was hers genetically linked? So genetic profiling is something that's available nowadays, Maisie, even though it is expensive, but it is present there. Some labs do it. So I think it's important that she sends her children to have those tests performed, because putting very young individuals through a colonoscopy at an early age could be traumatic. So, I mean, I would start off, if Stacey did have colon cancer at the age of 25, genetic profiling, I think, is important for her children. I would start off with that. And usually in the teenage years is when we would start doing screening for her children.
All right.
And all her siblings, let's say if Stacy at the age of 25 had colorectal cancer diagnosed, at the same stage, an advice should have been given out for Stacy to have all her siblings to be screened as well. So the question is very good, Maisie, because she also asked about at what age you would start colorectal cancer screening. So for the sporadic cancers that happens in older individuals, as we know, about 90% of tumors occur in individuals for more than 40 years of age. And what we mentioned early on is that we would recommend screening slightly earlier, 45 years of age. For those with a family history, normally when it was 50 years, we would ask them to start at an earlier age, maybe 40 years. So if we bring the age down to 45, we may consider even the 35 or late 30s age group to start screening for those with a familial history.
Okay. All right. Thanks, Datuk. Stacey, we hope that answered your question. So get your sister screened. Stacey is a friend of mine in my young cancer survivors group. Yeah. So she's gonna have a first child soon.
Oh, excellent.
Yeah. So thank you all for your questions. I know there's a few other questions. I'll try to answer them by asking Datuk later on. Thank you all for joining today's session, and thank you so much, Datuk, for answering everyone's questions today.
My absolute pleasure, Maisie. I'd like to thank you, Maisie, for doing a fabulous job in being an ambassador for not only for colorectal cancer, but for cancer as a whole. I think you're a role model for everyone. I mean, it's very difficult to talk about something personal related to your condition, and you've done a fabulous job to educate everyone. And I hope you keep spreading the news and the warning signs, symptoms associated with all types of cancers. And I'm sure that there are many people and individuals who will benefit from all the good work that you've done, Maisie.
Thanks, Datuk. Thanks a lot, everyone. I'll tell you how to win it. It's very simple. How you're going to win the Prince Court Medical Center health screening packages worth 600 ringgit is just share this live stream and tag Prince Court Medical Center. Please do that. You can also hashtag PCMC, which is basically short for Prince Court Medical Center. So how to win the health screening package is share this session, tag Prince Court Medical Center, and hashtag PCMC. And we'll pick the 2 winners at random. Thank you so much, Datuk Yunus, and thank you all for your questions.
Thank you, Maisie. It's been a pleasure seeing you again and speaking to you.
Yes, thank you so much. So I'll end today's live stream. Next week, we're going to have a session with Dr. Hajit Kaur on breast cancer. So please join us if you have questions regarding breast cancer and more about early detection as well. Thank you all, and see you guys next week. Thank you so much, Datuk.
Thank you. Take care, Maisie.
Take care. Thanks, Prince Court Medical Center, and good luck to all of you to win the health screening package worth 600 ringgit.